Okay. Good evening, everybody. And Assalamu alaikum wa rahmatullahi wa barakatuh. Today we have a lecture how to approach or how to interpret chest X-ray in emergency and non-emergency examination. And inshallah, this lecture will be divided into two sessions. Each session between 1 hour or 1.5 hours. Before we start, I invite you all to join to my lecture to interpret emergency and the non-emergency examinations for the chest. And before we start, I need to notify something that, to be honest with you, chest X-ray is one of the most difficult examinations that you have seen. Why? Because the chest X-ray, different parts in the body, there is summation of different parts in one projection, either BA projection or lateral projection. So my recommendation to you to have 2 points when you start to read chest X-ray. First point, you should have a checklist, and this one that we will do today. And second point, don't be satisfied by the lesion. If you pick up a lesion, don't be satisfied. Maybe there is another lesion, maybe there is another key to diagnose the lesion. So we can start by a small introduction or brief introduction. For chest X-ray, we have 4 major views: posterior anterior view, anteroposterior view, lateral, and lateral decubitus. And by the way, lateral decubitus, this one is the least one that requested by the clinician. If we see the BA view, this BA view is the standard view for routine chest X-ray. It's taken in full inspiration. And how can we differentiate between BA and AB views? BA posterior anterior view. AB is anteroposterior view. BA view, the heart is close to the cassette, so the heart will be in proper size. Okay, and while AB, the heart is away from the cassette, so it appears falsely bigger or larger than the BA view. This is the most crucial point that you need to know. Also, how to differentiate here. In the BA view, you will see the clavicle is crossing the lung fields, while the AB view, the clavicle is slightly away from the lung fields. Also, again, we have here the heart size is a normal size, it's actual size, but here it's slightly bigger than the normal. Also, we have the posterior ribs is more distinct in the posterior anterior view, while the anterior view, the anterior ribs is most prominent or more distinct. Anyway, I need from this point to verify that the heart may be slightly enlarged in the AB view and maybe not true. So don't judge or don't estimate the cardiac size in the AB view. We have also this lateral view, as you know, and we have also lateral decubitus view. Lateral decubitus view, as you see here, the patient lying on the right side or on the left side, according to what is the indication, and we have the X-ray tube will be from lateral side to have this view to the patient. And this one is very important to demonstrate small pleural effusion or pneumothorax. According to the exposure, I think this one, by the new edition of X-ray machines, we don't have any problem regarding the exposure, but for you, this X-ray chest is the standard, and this is the ideal one. You can hardly see the dorsal spine behind the heart. This is the classic or the standard exposure. This is the hard film that the lung parenchyma appears black, and this is the most soft film. This we couldn't clearly identify the dorsal spine. So this is the standard, and this is the ideal exposure for the chest X-ray. Another point regarding the position of the patient, we should have a good quality of X-ray. How can judge? We can judge this one first by exposure, and second thing regarding the rotation. If we put a line parallel to the trachea, you have equal distance between the trachea and the clavicle on both sides. Look for this one; it is not equal, so the patient is slightly rotated, and this one may affect the quality of the image. For the normal X-ray chest, you should have this clear lung field on both sides. And I need you to concentrate for this point. This is the most important point in our lecture. You should know what is the normal to know what is the abnormal. First thing, you can see the lung fields clear on both sides. You will see the bronchovascular markings going to the periphery of the lungs. This is the most important. And all the length, all the anatomy will be well defined. For example, we have here the aorta. We will have here the cardiac border, left cardiac border, right cardiac border. It's clear. Diaphragmatic copula, left side and right side, it's clear. The hilum is in arborized form, or there is a good arborization for the left pulmonary artery. Arborizations means branching, like this one and this one. And by the way, always the left hilum is slightly higher than the right hilum. We also have this bony cage reps, and we should know how to identify which one this rep. This is the first rep. You can take the rep from the posterior to anterior. This is the first rep, and this is second rep, third rep, fourth rep, fifth rep, sixth rep, seventh rep, and all of this. And again, you should have a clear outline. What does it mean, clear outline? We don't have any paratracheal masses, no paratracheal shadows, no mediastinal shadows. We have also clear costophrenic angle. This one is called cardiophrenic angle, as we will say later on, and this one is costophrenic angle. We also have this gastric bubble, and between the gastric bubble and left diaphragmatic copula, it's not exceeding more than 1 centimeter. And we don't have here any gas lucency on the right side. Again, this is the first rep. So this is the first space. This space contains aortic knob. This is the second rep, and this is the second space. There is a pulmonary artery trunk. And we have here third space, left atrial appendage, fourth space, and fifth space, and like this. And we have here paratracheal strap. We don't have any paratracheal masses, either on the left side or right side. We have the arborization of the pulmonary artery. We have here paraspinal lines for the aorta, and we have diaphragmatic copula left and right. And by the way, this paraspinal lines is one of the most important points in many diseases that we discuss later on. So you should know what is a normal to know what is abnormal. Again, we have here the upper loop, and this is the middle loop, and this is part of the lower loop. Here, we have here the upper loop, and this is part of the lower loop. You can see the lower loop and upper loop, there is an overlap in this part. Sometimes you couldn't identify, is it in the upper loop or lower loop, especially if it's in the lingula, for example. We have here, this is, as we said before, this is the cardiophrenic angle, left side, and this is cardiophrenic angle, right side. And we have right diaphragmatic copula and left diaphragmatic copula. How can we identify right from left side? Simply, the diaphragmatic copula that overlies the gastric bubble, this is the left side. The another one is slightly higher. This is a normal X-ray. You should also see in the lateral view, the vertebral column, one of the most important points, and the sternum, and this retrosternal space should be clear and dark. and retrocardiac space should be clear and dark. This is trachea. This one is another triangle, should be clear and dark. So we have here in the first space aortic knob, pulmonary trunk, atrial appendage, and this is the left cardiac border, and this is the right cardiac border. Here is the same cardiac anatomy. We will go rapidly to one of most important normal variant, what we called azygos fissure and azygos loop. This one of the most common normal variant. There is a lot of many variants in the chest, but this one is the most important and most common one. And this is the lateral, as we said before, there is a dorsal spine, and we have here the ribs, and we have here cardiac shadow, and this is the hilum, this trachea, this retrotracheal space, and this is the retrosternal space, and this is the breast shadow, and those are the both diaphragmatic copy. And this one is called costophrenic angle. In the lateral view, you should see two costophrenic angles. The higher one is the right side, and the lower one is the left side. Also, you can see in the AB or BA view the hilum, and the hilum always, the right pulmonary artery is in front of the right bronchus, and the left pulmonary artery is higher or above the left bronchus. Always the left hilum is higher in position than the right hilum. This is trachea. You can see the tracheal division, and this is the carina, and we have here is the trachea. Again, this is trachea, and this is the left pulmonary artery, and again, you should see this arborization for the left pulmonary artery and right pulmonary artery. We have here cardiophrenic angle and costophrenic angles. For the cardiac size, you can measure the cardiac size in two ways. You can measure here cardiothoracic ratio, and you can measure the width of the chest, should be less than half of the chest. You can also draw a line vertical, and you can also two lines perpendicular to the most widest point of the heart, and calculate together, and should be again half of the total width of the chest. We can divide the lung into upper zone, middle zone, lower zone, and this is that we always report. In reporting of the chest, we can write in the upper zone. Upper zone, it doesn't mean upper lung loops. Upper zone from the lung apex to the second rib anterior. This is the first rib, and this is the second rib anterior. From the second to fourth rib anterior, this is the middle zone. It doesn't mean middle loop. And lower than this one is the lower zone. Again, we have here, post lung fields are clear. We have here an azygos fissure and azygos loop, one of the normal variants. We have two different checklists according to what you like to do, or according to what you like to practice. We have a standard checklist, and this is present in many sites, internet sites, and many locations, starting from A to L. A, regarding pneumo, any air in the chest. B, bones. C, cardiac shadow. D, diaphragm and subdiaphragmatic region. And E, effusion. F, field. G, gastric bubbles, hilum and mediastinum. Interstitium, you can search for fibrosis or nodular infiltrates, and you can search for lines. Really, I made some modifications in this checklist to be easier for you to know, and according to your, according to what you like, you can use this one, or you can use another checklist. This checklist, I made it to be more simple and more easy to memorize. We can start by 3B. 3B, pneumo, 3 pneumo. We are searching for air. So you can search first point for pneumothorax. And pneumothorax, you can see Pneumothorax inside the pleura, so you can see air and water, pneumothorax and pleural effusion. Second, pneumomediastinum. Third, pneumopericardium. So we have here three pneumothorax, pneumomediastinum, pneumopericardium. And if you want to add 4B, it will be pneumoperitoneum. But let us see if we can do it like this. We have 3C for the lung and the cardiac pathology. Consolidation, there is a first C, collapse, and the cardiac shuttle. So we have consolidation, collapse, and the cardiac shuttle. If we go to the consolidation, you are searching for any lung pathology in this point. You can see consolidation and cavitation. Cavitations may be bronchitis also. And we also need to search any opacities in the lung. Opacity includes nodules if it's small. If it's larger than 3 centimeters, it will be masses in the lung. So we have nodules and masses. And we have 2 points. One of these points reduce the inflation of the lung, what we call fibrosis, and another point that make hyperinflation of the lung. Two opposite items, it's emphysema. So we have consolidation, cavitation, opacities means nodules and masses, then fibrosis and emphysema. We have to clarify if there is any collapse of any loops or not, and we can see the cardiac shadow. And this cardiac shadow, you should know what is the signs for pulmonary edema and pulmonary hypertension. We also have 3B. You should see behind the heart, one of the most important hidden areas. Below the diaphragm and diaphragmatic lesions, you can search for any pneumoperitoneum or air under diaphragm. You can see the breast shadow. You should know if there is any mastectomy or not. Sometimes it will solve for you the dilemma. The last point, you can take midline to outside technique. Midline to outside means we should see the lines like endotracheal tube, portacast, or any lines that will be in the patient. Mediastinum, this is from the midline, lines, mediastinum, then hilum, then another hidden areas. We can also pick up any hidden areas we will talk later on. And bony cage. Bony cage is starting from the clavicle, ribs, sternum, scapula. All of these should be viewed to avoid any missing points. So we will search in any chest X-ray for the 3 pneumo, 3C, consolidation, collapse, cardiac shadow, and 3B, behind the heart, below the diaphragm, breast shadow, and midline to outside technique. Today in our session, we will divide these points. We will discuss part of these points, and inshallah, next week we will complete the other points. This is a normal X-ray chest. How can we know it's normal? First, we don't have any pneumothorax, no pneumomediastinum, no pneumopericardium, no consolidation, no collapse. The cardiac shadow is normal. We don't have anything behind the heart, below the diaphragm, and the breast shadow is not appear here because it's a male patient. From the midline, we should have here no lines applied for the patient. You should see the trachea is central, no paratracheal shadows. The mediastinum is clear, the hilum is clear. The hidden area, we will discuss later on what are the hidden areas. And later on, the bony cage. You should see the ribs, clavicle, scapula, humerus, all the bony cage will be viewed. We will start by the first one, it's pneumothorax. Pneumothorax, how can you identify the small pneumothorax or subtle pneumothorax? You will search for this line. I think you should know this one is a visceral pleural surface. It's crossing the ribs. Another point that you can judge or pick up pneumothorax is the bronchoscopy markings. It will be stopped here. Later on, you will see jet plaque without any bronchoscopy markers. So we have two key points to diagnose pneumothorax. You should see the splitting of the visceral pleura from the chest wall. You can search, you must search for this line. If you don't search for this line, you will miss it. It's very easy to miss. And you search for any jet plaque without any bronchoscopy markers. This one is subtle pneumothorax, subtle pneumothorax. How can we identify the subtle pneumothorax? This one is in the upper lung zone or the upper hemithorax and not exceeding 2 centimeters. Here also we have here, look here, this is a normal lung field, but look for this side. This is the visceral pleura, you can see it. And this is the pneumothorax, this is jet plaque, and this is the bronchovascular markings reaching the visceral pleura. So we have here small pneumothorax. Why it's small pneumothorax? Because it is exceeding 2 centimeters here, but it's not reaching the lower hemithorax of the chest. Here it's massive pneumothorax. Why? It's exceeding 2 centimeters and involving the upper and lower hemithorax. So we have here large pneumothorax. It's more clear here. This is a visceral pleura. It's easy to identify in the large pneumothorax. And this is jet plaque without any bronchovascular markings. We have here in this side visceral pleura, and this is the right side pneumothorax. Here you can see extensive or massive pneumothorax, and this is the collapsed lung. This is a collapsed lung. Here also we have pneumothorax here on the right side, and we have also here on the left side pneumothorax, and we have bubbly lucent lesions in the chest. Emphysematous changes, maybe Bolli formation, and maybe this is the cause for the pneumothorax in this patient. So we have here bilateral pneumothorax. We have an important signs for the pneumothorax, especially if the patient is in casualty in the ER and you couldn't take or you can't take an erect view for the patient. You will not see the pneumothorax as you saw before. So how can we identify the pneumothorax in the supine patient, supine portable patient? In the supine portable patient, you will see this sign, what we call the deep sulcus sign. What does it mean, deep sulcus sign? This is a costophrenic angle. This is a normal costophrenic angle. You will see deepening or lower level and lucent costophrenic angle in the supine position for the patient. You have to suspect that this patient maybe there is a pneumothorax. You can ask or you can request or you can try to make an erect view to be confirmed. And also sometimes the hemithorax will be slightly lucent than the right side. It's difficult to identify, but you can judge or you should search for the costophrenic angle, deep sulcus sign. Another one, this is a deep sulcus sign. As compared to the right side, this is a normal, but this one is lucent and going deep inside, deep lower level. Also, we have here, this is a pneumothorax and this is a visceral pleura. Yeah. Here we have another point and another dangerous point. This is a pneumothorax. Yeah, you are right. But this pneumothorax is associated with mediastinal shift. You will see here the trachea is shifted to the right side, and the mediastinum and the heart is shifted to the right side, and the diaphragmatic copula is flattened, not like this one. So you have here tension pneumothorax, one of the most serious and critical points. So once you pick up pneumothorax, okay, you will search for any mass effect for this pneumothorax. Tracheal shift, cardiac shift, diaphragmatic flattening, all of these points or all of these signs indicate tension pneumothorax needs immediate intercostal tube and intervention to relieve this pneumothorax. Another point here, this is the pneumothorax on the right side, and the lung here is collapsed on the right side. Another point here, we have here air and water, most likely hydropneumothorax. Like this one is air and water, air fluid level without any bronchovascular markings. So we have here hydropneumothorax, and this is tension hydropneumothorax. We have here mediastinal shift and crossing to the midline. Even in the bad quality film, if you will see this costophrenic angle deepening sulcus as we discussed before, so this one is highly suspicious for pneumothorax. This also bilateral pneumothorax here on the right side and here on the left side. Here also we have here pneumothorax. Look for the visceral pleura. You should search for the visceral pleura. I'm sorry that I spent a lot of time in this issue, but it is considered one of the most important points in the chest X-ray. And by the way, in all chest X-ray, you can go with this checklist. Don't miss or don't forget the checklist. Sometimes or many times we saw chest X-ray in a routine or elective cases, and we pick up many abnormalities like this. Here, if you can see here, this is pneumothorax. How can we know? This deepening of the costophrenic angle, and we have here like leveling of the pneumothorax. It's one of the most difficult point, but you will see if you concentrate too much, you will pick up there is no no bronchovascular markings in the periphery of the lung, so you can suspect here pneumothorax. This is what we discussed before. Yeah, we will jump to pneumomediastinum. This chest X-ray, you can see here streaky lucency in the mediastinum. You can see this one. You should be familiar with this one of the most important emergency. This is a pneumomediastinum. Streaky lucences inside the mediastinum. This extensive surgical emphysema, like this one, once you see surgical emphysema in the chest wall, directly you should exclude by all means if there is any possibility for pneumothorax or not. This is one of the most important point. This one here, massive pneumothorax with surgical emphysema in this side. If you search here, you will see the pneumopericardium. This is the pericardium, and this is a cardiac shadow, one of the most difficult point. But if you are searching for the checklist, you will not miss. Here it's very easy to see gas or lucency between the mediastinum or the pleura and the pericardium. If we are talking with pneumopericardium, you should also see the pericardial effusion. Pericardial effusion, as we see in this image, what we called water bottle sign. Water bottle sign. That's it looks like cardiac enlargement, but without any features, without any borders. It is smooth border, stenciled border, as we always say, like this one, water bottle sign, without any configuration. The heart loses its configuration. Also in the lateral view, you can see this classic sign for the pericardial effusion. You can see this is the effusion. How can we identify this one? This is the pericardial effusion between two straps of bed, and this one. In the retrosternal space, like this one, may identify pericardial effusion. You should be familiar with this one. Pleural effusion, one of the most important point, as we discussed in our checklist, we should search for the three pneumo. Pneumothorax, with the pneumothorax, you should exclude pleural effusion. With the pneumomediastinum, and pneumopericardium, you should exclude pericardial effusion. So pleural effusion, this one you will see here, this clear costophoric angle, but this one is obliterated. So we have here a mild pleural effusion, mild right side pleural effusion. We have here a massive left side pleural effusion. A good sign is it rising to the axilla, and we have a mediastinal shift to the right side. So we have here a massive left side pleural effusion. We have here right side pleural effusion rising to the right side, and we have here left side pleural effusion. This is one of the most important point, pleural effusion on the right side. It's clearly identified, but I need you to concentrate in this point, because this one of the most important points that may be missed. Here, as we discussed before, the right hemidiaphragm is higher than the left diaphragm. This one is one of the most important features because of the liver, but it should not be higher like this. This one exceeding 2 spaces of reps. So you have suspicious. Maybe there is something below the diaphragm, maybe something in the chest. This is classic form of subpulmonic pleural effusion. It is subtype of the pleural effusion, and we can see it. It's relatively common, and we can see it on the right side like this one. The diaphragmatic copula is slightly higher than the left side. And another point for this one to be confirmed: the peak of the diaphragmatic copula is laterally. Look for this one. The peak of the diaphragmatic copula here is a mid-clavicular point, but here it is shifted to the lateral aspect, shifted to the right side. So you can suspect subpulmonic pleural effusion. This one is the left side subpulmonic pleural effusion in this side. This one is very easier to identify. The left copula is higher than the right copula, so there is something wrong. Maybe below the diaphragm, maybe inside the hemisthorax, maybe the diaphragmatic paralysis, something like this. So you should know this is the left diaphragmatic copula, and we have here increased the distance between the gastric air bubble and the diaphragm, and this one is the key point to diagnose the left side subpulmonic pleural effusion. This space should be less than 1 centimeter. Here you are exceeding 2 centimeters, so you are suspecting subpulmonic pleural effusion. As we said in the first of the lecture, you should know what is the normal to know what is the abnormal. Here, there is increased distance between the left diaphragmatic copula and the gastric air bubble, so you are suspecting subpulmonic pleural effusion. If you are suspecting subpulmonic pleural effusion, how can you identify? This is the crucial point that we need to add in this lecture. You should request lateral decubitus view. For example, if you are suspecting here subpulmonic pleural effusion, you will ask to do left lateral decubitus. Left lateral decubitus, it will clearly identify this type of subpulmonic pleural effusion, because the effusion will move from the basal side to be spreading, or to spread to involve the whole hemisthorax, making this picture. It's very easy to identify and very easy to exclude. So if you have any suspicious for pleural effusion, you can ask for lateral decubitus, either left lateral decubitus or right lateral decubitus, according to the side that you are suspecting. Here, to finish up these pleural diseases, we have here these leafy-like shadows. It's one of the most important opacities. You can see this is pleural plaques. It's classic or characteristic for the pleura. It's leafy-like shadows. It's pleural plaques. Sometimes you can identify calcified pleural plaques here in along the diaphragmatic copula. Look for this one. Yeah, I know.
You will receive a new link now. New link again to the meeting, because the time is late, finished an hour now. I will send you a new link now.
Okay. Okay. So we have here to close the pleural diseases, we have here a pleural plaques. We can identify it bilaterally, and this one is most commonly associated with asbestos infection or something like this. So again, this one is a pleural plaques, calcified pleural plaques over the diaphragmatic copula, and there is a leaf-like shadow. It's not in the lung, but it's in the pleural. So again, our checklist, we should exclude 3B, pneumothorax, besides the pneumothorax, pleural effusion, pneumomediastinum, pneumopericardium. So we are now shifting to the 3C, consolidation, cavitations, bronchiectasis, opacities, nodules, masses, fibrosis, and emphysema. By the way, this lecture is recorded. Maybe I am saying many informations in a rapid way, but you can hear this one later on. So we have here consolidation and cavitations, and we have here nodules and masses, and we have fibrosis and emphysema. Fibrosis reduce the lung volume, but emphysema increase the lung volume. So we'll go to the lung pathology. Lung pathology, you can search for any consolidation in the chest. I think many of you or most of you know how to identify the consolidative patch. It is air space opacities. By the way, we have two different categories of to visualize the lung pathology. Is it interstitial disease or air space disease? Air space means alveolar shadows or acinar opacifications, but interstitium means interstitium infiltrations or fibrosis or nodules in the interstitium beside the alveoli, as you know from the pathological background. So you can here see this is alveolar shadows. Consolidation means alveolar shadows. It's most common to be ill-defined, like this one, this involving the right upper lung zone, and this one involving the middle and lower lung zone. But take care, this one or this opacity, you should know, or you should clearly identify the left diaphragmatic, sorry, the left cardiac border. Here we have here a small opacity, left basal, maybe exceeding or maybe spreading behind the heart. This patchy pneumonitis or patchy consolidation. Also, we have here, it's very clear to have left upper lung loop pneumonic patch, and I need to stop in this image for a while. You should see the air bronchogram going inside this alveolar shadow or this consolidation. What is the significance to see this air bronchogram? What does it mean, air bronchogram? It's the air inside the bronchial division. You should see it as the lucent lines inside the consolidated patch. What is the significance to this one? This one signifies that you don't have any bronchial obstruction in the hilum. You don't have any bronchial obstruction. You have here most likely infection or infectious disease involving the left upper lung loop. This is the significance of the air bronchogram. Another point or another one, this right upper lung loop, it's loopor pneumonia or consolidation. You should see the air bronchogram. The significance of the air bronchogram exclude central obstruction and make the diagnosis confirmed or more with infectious disease. Here, you should compare between the left side and the right side. You will see here a patch opacity not present like this one. So if you go with a checklist, we don't have pneumothorax, we don't have pneumomediastinum, we don't have pneumopericardium. So shift to the lung pathology. First one is consolidation. Yeah, you have here patch consolidation. Always compare right side to the left side, especially if the patient is centralized. This one is patch consolidation, and this one is a patch consolidation. And by the way, we need to clarify an important point in this issue. If the patient on follow-up, you have a persistent consolidated patch, especially in patients more than 40 or more than 50, you should exclude bronchoalveolar carcinoma. It has a similar appearance to the simple consolidation or the simple pneumonic patch. So if you have a patient more than 40 or more than 50, and there is a persistent cough and persistent symptoms, and the chest X-ray, there is a persistent opacity, in spite of treating the patient, you should shift to the CT chest to verify the possibility of bronchovascular carcinoma. Always here, this one is a patchy consolidation, and this one will appear here as a triangular patch in the lateral view. This one may be pneumonic patch, but in this patient exactly, you should search for if there is any possibility to be pulmonary infarct. Why it's pulmonary infarct? Because it's a peripheral location, it's triangular or wedge shape, maybe simple consolidation, maybe pulmonary infarct. So you should, if the patient has a history of DVT, or if there is a possibility of pulmonary infarction, you should go to the CT pulmonary angiography. Yeah, this one is a supine patient, and as you see here, what is the abnormality here? This one, you can hardly see there is a patchy opacity in the peripheral locations. Maybe present, maybe not, but I think it is here in the middle lung zone, it's clearly identified. Maybe here for a little bit, it's suspecting, but here is a patchy opacity. If we shift to the CT, this CT for the same patient, I add this one. I know this one is out of our lecture, but if we have bilateral patchy opacity, subpleural opacities, or subpleural consolidative patches, here it's what we call the ground glass opacities. We will differentiate now between the ground glass and consolidation. But in this patient, we have a peripheral patchy opacities, more on the basal lung zones, and this is a typical for COVID-19. So if we see the chest X-ray again, it's hardly to see this patchy opacity, but you should search and play in the window of the X-ray to pick up any abnormality. If the patient is suspecting COVID, managed as this patient is a COVID, as you follow the protocols, but we need to know what is the classic features of COVID cases in the CT, multiple peripheral ground glass and consolidated patches. Here, this is a classic form of COVID in the patient. Here is a peripheral patchy opacity. I think the right side is more pronounced. Here it's bilateral, it's clearly identified in the chest. We have here patchy opacity, here patchy opacities in the lung. It's highly suspicious for COVID. This one is a classic form in the CT for COVID cases, peripheral patchy opacities in both lung fields. This patient is very important to identify. This is a chest X-ray for one patient. It looks like normal. We don't have any identified patchy opacities, but this patient, if we did for him CT, there is a patchy consolidation or patchy ground glass peripherally located in the right side, and this case is confirmed to have COVID disease. So the chest film is insensitive early in the disease. There is a comparison between chest X-ray and CT. CT is most sensitive for the patient. What is the rule for the chest X-ray in the COVID cases? It can be used mainly in the follow-up of the disease, especially in the severe cases. What is the specific CT COVID features? I'm sorry to add this one to our lecture. I know it's not related mainly to our lecture, but it's just 2 or 3 slides to know what is the specific features for COVID cases. This one is ground glass opacities. What does it mean, ground glass opacities? This is a normal lung parenchyma. It's dark, and there is lung vasculature normally appearing. This one is like as you see anything in front of glass. In front of glass, you will see haziness, not a clear image. This one, what we see. This is what we call ground glass opacities. This one is called ground glass opacities. But take care, inside the ground glass, you can see the vascular markings of the lung. This is the most important point to differentiate between ground glass and consolidative patch. Consolidative patch, it's patchy opacity, but you couldn't identify the bronchovascular markings inside. One of the most specific features also, sometimes there is a dilatation of the vascular markings inside the subpleural patchy opacity. Here, also, there is another features, what we call the bronchiectasis inside the patchy opacity. Look for this one. This is a consolidative patch. Why it's consolidative patch? Because we couldn't identify the bronchovascular markings inside. Here, you can identify the bronchovascular markings. So it's ground glass. Here, it's normal. This is a normal lung parenchyma. This is a ground glass, but this one is consolidative patch. Inside this consolidative patch, you should not see this bronchial tree dilated like this. You can see the bronchial diameter like this one beside the hilum, but at the periphery, you should not see bronchiectatic changes or bronchial dilatation in the periphery or inside the consolidative patch. Those are one of the most characteristic features for COVID cases. This one, this is another patient classic for COVID. We have multiple bilateral ground glass opacities, mainly subpleural. Here, it is subpleural. And this is the progression of the case. This fibrotic bands appear later on. And this is the end stage, or not the end stage, it's with the progression of the disease, the ground glass will be turned into consolidative patches and will be associated with the fibrotic bands and sometimes bronchiectatic changes that, as we discussed before. And we have here the architecture of the lung parenchyma, not like this one. It is distorted. So we have some sort of interstitial fibrotic changes. This one can be seen in the end stage of COVID disease. Based on the concerns, the American College of Radiology in the last update, March 22, 2020, CT should not be used to screen for or a first line to test or diagnose COVID-19. CT should be used and reserved for hospitalized symptomatic patients with specific clinical indication. For CT, facilities may consider deploying portable radiography units in ambulatory care facilities. Some medical practice are requesting chest CT to inform decisions on whether to test a patient for COVID-19, admit a patient, or provide other treatments. The ACR strongly urges caution in taking this approach. Normal CT doesn't mean a person doesn't have COVID-19 infection, and an abnormal CT is not specific for COVID-19 diagnosis. The most important signs for COVID cases: ground glass opacities, bilateral involvement, posterior distribution, multi-looper involvement, as we saw before, peripheral distribution, and consolidation is the least one. In the early stage, the ground glass appear, then with progression of the disease, extension of the ground glass, then turn to be consolidation, and with improvement of the patients, there is gradual resolution of the consolidation. So we are now shifting to another pathology, pulmonary cavity. Here is the pulmonary cavity. This is a classic appearance for the pulmonary cavity. We have a long list of differential for pulmonary cavity, starting from carcinoma, autoimmune disease, vaginal granulomatosis, vascular infection, trauma. Sometimes it's congenital, but it's for you how to pick a cavity in the lung. This one here, a cavitating mass or cavitating lesion in the left middle lung zone. Maybe neoplastic, maybe infectious, something like this. We need to shift to do contrast enhanced CT. Another form of cavitations here and here. Multiple cavitary lesions may be septic emboli, pulmonary emboli, but it's the most difficult point to pick up the abnormality. This is the most important point. You need to search for the abnormality. If you're not searching for the abnormality, you will miss it. It's easy to miss. Here it's pulmonary cavity, very clear here. You should identify this cavity from the hilum. This one is easy to identify. This one shows thick, smooth wall and air fluid level. This one it's considered under the cavitary lesions of the lung. Here you can see cystic spaces. This is bronchiectasis. This is bronchiectasis. You can see very clear cystic spaces like this. This is bronchial markings or the bronchial wall. It is thickened, and inside these bronchial walls, you can see this. You can see these cystic changes. This is bronchiectatic changes. We are now shifting to see the pulmonary nodules in the lung. If you can classify the nodules, we can classify this one into miliary nodules if it's below than 2 millimeters, pulmonary micronodules from 2 to 7 millimeters, pulmonary nodule from 7 to 30 millimeters, pulmonary mass above 30 millimeters, and above 3 centimeters. So below 3 centimeters, it's considered as a nodule. If it's below than 7 millimeters, it's micronodule. If it's lower than 2 millimeters, it's miliary nodule. Pulmonary mass above 3 centimeters. So we have here, for example, this is chest X-ray. We have here multiple pulmonary nodules, and we have here a mass, right parahilar mass. We have here multiple masses, and we have also here nodules. The solitary pulmonary nodule have a long list of differential diagnosis, starting from granulomas, pulmonary carcinoma, adenomas, lung abscess, incysted pleural effusion. Sometimes it's appear like pulmonary nodule, zooted tumor, pulmonary hamartoma, hydatid, rheumatoid nodule, vaginal nodule. 40% of the solitary pulmonary nodule are malignant. So be careful, and you should search for this nodule. Look for this one; it's clearly to identify. But sometimes this one is large mass, left parahilar mass. It's irregular in shape. Sometimes the pulmonary nodule, it's difficult to identify. So you should go with a checklist. We have 3 pneumo, then we are going to consolidation, cavitations, then nodules and masses. You should search for the nodules in each part of the lung field. For example, here, we have here pulmonary nodule. And we have also here pulmonary nodule, and we have here pulmonary nodule. Sometimes the pulmonary nodule can be hidden behind the hilum, like this one. You should also see like this one. All of this one, this mass, not nodule, it's very large. You should see the dorsal vertebral column more clear, and when you are going more low and low, you will be more lucent. Remember these basics. If you are going for the dorsal spine from above to downward, here you can see like an opaque vertebral column. If you are going down and down, you should be more clear and more dark. More darker when you are going down. This one is the most important, one of the most important features in the lateral X-ray to identify if there is any consolidation, any collapse, any masses, something like this. If you are going inside here, down, you will pick up this mass. Sometimes one of the hidden areas, if the mass here, like this one, besides the diaphragmatic copula, one of the most important point, this is a bronchogenic carcinoma beside or behind the diaphragmatic copula. You should see clearly the diaphragmatic copula. You should clearly see what is below the diaphragmatic copula. This speculated mass, typical case of bronchogenic carcinoma. Here, if you concentrate. There is no pneumothorax, no pneumomediastinum, no pneumopericardium. So do we have any consolidation? We don't have any consolidation. Do we have any cavitation? We don't have any cavitation. Nodules and the masses starting from above to down. Here, 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 here. No nodules, no masses. Here. Yeah, this one. Look for this one. One of the most difficult point. This one is a classic pulmonary mass. It looks like speculated. There is suspicious of abnormal density. Just you can pick up abnormal density. This is a pulmonary mass in the right lower lung lobe. Look for this one. This is a nodule. No, this is a not. It is not a nodule. Once you see nodular lesion like this in the middle lung zone, go to the another side to see if it's appear in the another side or not. It is typical nipple shadow. Nipple shadow. Nipple shadow can appear smoothly like this one. You can one of the pitfalls for the pulmonary nodules. If you can see this nipple shadow, you can search for the contralateral side. The nipple shadow appears in one side it's more defined, but the another side it's ill-defined. One of the most characteristic point to differentiate, is it chest wall nodule or pulmonary nodule? Pulmonary nodule or pleural masses or chest wall masses, this one has a characteristic well-defined border and ill-defined another border. So it's easy to identify the nipple shadow if you pick up another one in the same level, same appearance. Here it's classic form for hilar mass. This one is a hilar mass. Look for this one. This is a normal hilum, as we said before. We have here normal arborization for the hilum, but this one it's speculated mass or speculated density, most likely hilar mass, most likely bronchogenic carcinoma. And we have also here paratracheal shadow, as we discussed later on. Before, as we discussed before, there is the paratracheal shadow should not appear, should be lucent. This one is a paratracheal shadow, pleural effusion. Okay. You hear me?
Yes, I can hear you.
Okay.
Doctor?
Complete? Do you see my screen?
Yes, I can see you.
Okay. 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 So we have here a cavitary mass.
Excuse me, doctor, we can see you, but not the screen.
Okay. Just a minute.
We not in need for the screen. We need to see Dr. Muhammad.
Just a minute, please.
Okay, doctor, we have around 10 minutes left now.
Yeah. Okay. خلاص. Okay. I need 5 minutes, not more. Okay. So we have here a cavitary mass in the right upper lung apex. We have here another mass in the right lung apex, but we have here a destruction or erosion for the reps. This is a normal reps, and this erosion for the reps. So it's classic form for pancreas tumor. We have also miliary nodules, miliary pattern These multiple nodular patterns, small, less than 3 millimeter, multiple innumerable nodular shadows in the post-lung fields. We have a list for differential diagnosis starting from familial TB, sarcoidosis, histoplasmosis, and don't forget miliary metastasis from thyroid, renal, breast, prostate, and osteosarcoma. This is a classic form for miliary metastatic diseases. We have here multiple pulmonary nodules as well. This larger than 3 centimeters, so this is a mass, and other nodules is most likely metastatic. I think, do we have time to, how many minutes do we have here, Imes? I think we can go to describe this last point regarding the fibrosis in the lung. You will see reticular shadows, multiple reticular shadows, and you can see reduced lung volume. How can we judge there is a reduction in the lung volume? Normally, if you pick up the first rep, and this second rep, and this third rep, this fourth rep, fifth rep, and this is the sixth rep. Sixth rep, it's going to the dome of the diaphragm. So there is hypoinflation or reduced inflation. Normally, the seventh rep should divide or intersect the diaphragmatic copula. Once you see the sixth or fifth rep, so you have here reduced lung capacity or reduced lung volume. So we have here combined pathology. We have reticular shadowings and reduced or hypoinflation for some. So we are suspecting an interstitial fibrotic disease. And also another point regarding the shaggy heart border. Look for this one. You couldn't pick up a distinct heart border. This is another signs for reticular shadowing or interstitial lung fibrosis. This is one classic form for interstitial reticulations. Here also, interstitial reticulations. This one of our cases. This one, look for the interstitial reticulations here and here. Here, all of these reticulations more on the upper lung zones. And by the way, this one of our patients, and we did for him CT. It's clearly to identify these reticulations, and this one is more in the periphery, and we can pick up here. This is a key point to diagnose this case. It's esophageal dilatation. Esophageal dilatation with reticulations. You can go ahead with to diagnose scleroderma, one of the most important diagnosis. And we have also, if the fibrosis is more pronounced on the apical lung zones, you can suspecting that the patient has a TB or granulomatous infection. If there is cavitations or consolidated patches, something like this, so you can suspect or you can diagnose active infection for TB. Also, we have here distortion of the lung ABCs, and we have here fibrotic bands. And any fibrosis make traction. Look for this one. This is the left hilum. It's tracted, uplifted by the fibrosis. This one is confirming there is a dense fibrotic changes in the post-lung fields for the old TB. This one, the against for the fibrosis, it's hyperinflation. If you pick up first rep, second rep, third rep, fourth rep, fifth rep, sixth rep, seventh rep doesn't intersect the diaphragm, eighth rep intersects the diaphragm, and the diaphragm is flattened. So we have here hyperinflation for the lung. We have here emphysematous changes for the lung, and I think we can stop here. We finished almost half of our checklist, and inshallah, second session will complete the other checklist, and we can move to some special cases or some special situations. And I think we have I think 9 minutes or something like this. It's for open discussion, for open questions welcome to all participants, and thank you for attendance.
If anyone has question, I can open the mic.
We can, we are very thankful, Dr. Muhammad, for very nice presentation. Really, I was unlucky because I was outside. I just joined since 15 or 20 minutes. I don't know that you spoke about the mediastinal masses and retrosternal goiter or not.
No, not yet. Next session, inshallah. To be clear, we now finished part of checklist. Our checklist is 3B. We finished the pneumothorax and the pleural effusion. We finished pneumomediastinum, pneumopericardium, and we shifted to the lung, 3C, including consolidation. We finished consolidation, cavitations, bronchiectasis, opacities, nodules and masses, fibrosis, and emphysema. We stopped here. We have next session, inshallah, we will discuss how to identify the collapse, cardiac shadow, and 3B, behind the heart, below the diaphragm, breast shadow, and we will go midline to outside technique, including lines, mediastinum, hilum, hidden areas, and conication.
Okay, thank you very much.
Yeah, welcome. I think this session was recorded, and anyone of the hospital staff can hear it at any time.
It's very nice. Yes,
Thank you.
inshallah we can.
I think Dr. Ali has question.
Assalamu alaikum. Thank you, Dr. Muhammad. Thank you so much actually for your effort and for this initiative. Appreciation to this effort. Actually, it is a huge topic when you want to talk about the X-ray, CT finding, the radiological finding, and that help. And it's actually very nice arrangement, that 3B, 3C, and 3B. First of all, I want to thank all of also the attendee who attend, and for the Dr. Muhammad as he arranged.
Thank you so much. Thank you.
And hopefully, inshallah, we will have it, inshallah, as a weekly basis, such like this presentation, which has great knowledge and information, will help all of us. My question, actually, I joined maybe a little bit late, but I joined when you talk about the CT finding of, and it's good that when you mention about the CT finding of those with COVID. My question about those, when there is a feature or some radiological finding in a COVID CT scan or X-ray, when supposed to resolve this this finding? It's related to the patient's clinical situation, or it may take time. And the second thing, if you can just give us a brief, what is the rule of ultrasound chest and COVID also, because there is, I think, rule and talk about this. Thank you, Dr. Muhammad.
Yeah, welcome. I think as we discussed before, first of all, thank you for all of you, and thank you for Dr. Ali for joining us in this session. Regarding the COVID cases, if you have the case and the case is confirmed with a COVID positive case and the patient has no symptoms, it's no rule for the imaging, no rule for the chest X-ray and CT. Chest X-ray mainly indicated if the patient has symptoms. Why it's indicated to be a background? Chest X-ray is indicated for this patient to be a background if you need to follow up the patient. And this is the most important point of chest X-ray exactly in this patient. But it's not performed to diagnose the case as a COVID or not, because it's most of the cases, especially in the early phases of the disease, it will be negative and can be diagnosed by CT. If you don't have an ability to do swab or something like this, and you have a suspicious if this patient has a COVID or not, so you can go in this one to do CT. CT, in case of that, you don't have any swabs to do. Another indication for the CT, if you have a severe case, and sometimes maybe the swab is negative and you couldn't judge if it's COVID or not. This is another indication to judge the severity and to confirm it's COVID, is it COVID or not. Regarding the ultrasound, yeah, ultrasound has a rule to diagnose some parenchymal changes, but it's not commonly used and it's dependent. The most sensitive rule for the ultrasound, if it's associated with a pleural effusion or something like this, it's very easy to clarify if there is any pleural effusion or not. It's easy to clarify the volume of the effusion, detect parenchymal diseases like CT, for example. CT is even the MRI couldn't reach. The CT is a gold standard.
Okay, Dr. Muhammad, thank you. The first question, I mean, when I expect the radiological finding to be resolved after, or it is matched with the patient clinical situation. Or it will take time.
You will go to this one, this slide. It's very important to revise. This is the classic, the most classic progress of the patient. Early stage, it will take 4 days. Maybe early stage and resolve, but we are talking for the classic form. 0 to 4 days, then progressive stage 5 to 8 days, and peak 10 to 13 days, and the absorption stage more than 14 days. This is the classic features. Maybe the swab is negative, but still we have an opacity in the chest X-ray or the CT may persist for a long period. May the patient go to the early stage and resolve. Will not go and didn't go to the other stages. But the classic form is these 4 stages, and this is the period for each one.
Okay, thank you, Doctor.
Welcome.
So, excuse me?
Yeah.
Assalamu alaikum.
Wa alaikum salam wa rahmatullah.
Thanks, Dr. Muhammad. Really, it is very, very good lecture. Thank you so much. And really, I strongly encourage all residents, specialists, and consultants, please see this lecture if you did not see it from the beginning, because really this is the basics of the chest X-rays. And you can build your experience and your knowledge based on this lecture. So thank you so much.
Thank you.
Appreciate.
Thank you so much. Thank you. Welcome.
Anyone else has question? We have 1 minute left. I think, Doctor, no more questions.
That's okay. And inshallah, next session will be next week. We will discuss the cardiac shadow in details. We will discuss the mediastinal masses. We will discuss the proper for the lines like intratracheal tube and something like this, and the most complications that may appear. And we can discuss the hidden areas in the chest X-ray and some interesting cases that we can discuss later on to build up or to enhance or emphasize the checklists that we put it in the slides. Thank you so much.